Yeah. Okay. So our next presenter for the future section of our conference is Dr. Van Manen. Today, his talk is The Future of Ethics, Technologies, and the Medical Humanities. So he'll talk about how the medical humanities offer the opportunity to reflect on the ethics of past, current, and future medical technologies. Such reflections benefit from understanding ethics and technologies not as wholly separate entities, but rather that ethics itself is shaped by our design and use of technologies. So he will explore the meaning of ethics for medical technologies, provide examples of empirical medical humanities research that supports reflection on the future of ethics and technologies. So to introduce Dr. Van Manen, he's the chair in the ethics and director of the Dossetor Health Ethics Center here at the University of Alberta. He has a clinical practice as a physician in neonatal-perinatal medicine within the Stollery Children's Hospital. His research is primarily concerned with ethics situated within the tradition of phenomenology. So I'll hand it over to Dr. Van Manen.
I'm always really horrible with these little things you have to clip onto your shirt. Seems like the one day I decided to wear a sweater, and of course the sweater's too thick for the clip. Thank you so much for having me here and for organizing this conference. It's really a nice opportunity to be able to present amongst colleagues, friends, as well as students. Yeah, I was going to say I tend to work around babies, which means I have this really quiet voice. I turned it up now. Is that better? That's awesome. There we go. Perfect. So I don't have any conflicts of commercial interest to disclose. And before going further, I would like to acknowledge that our university stands on Treaty 6 territory, a traditional meeting ground and home for many Indigenous peoples, including the Cree, Saulteaux, Niitsitapi, Métis, and Nakota Sioux. Our university is a welcoming place for people, but it's important to acknowledge that it stands on appropriated land. For this presentation, I'd like to explore the connectiveness of technology, ethics, and the medical humanities. I hope to show that the medical humanities offers the opportunity to reflect on the ethics of past and future medical technologies. And I want to be specific there, technologies, because not all technology is equivalent. And each technology that we might use within our clinical practice can affect our sensibilities in different ways. Such reflection benefits from understanding ethics and technologies not as separate entities, but intimately woven together. I'd like to begin with 3 anecdotes which show everyday technologies that are formative of the ethics of where I practice, so the newborn intensive care unit. A premature baby lays in an isolette. A sheet cast over the housing mutes ambient light just as the plastic structure itself attenuates sound. Only traces of the outside world seem to be allowed in. Within, rolled towels support the baby's body in a position of flexion. His arms, trunk, and legs shift in subtle shudders before settling in stillness. The eyes gaze, yet seem to lack a point of fixation. What is life like for this child? What experiences of sight, touch, and smell exist for him? In the adjacent spot, a newborn is sedated and paralyzed as we struggle to maintain oxygenation. The baby lays splayed with only the chest moving, vibrating in response to the airflow of the oscillation machine. As we're talking, the baby's heart rate rises. With muscles relaxed, she cannot move, let alone open her eyes. Does she experience isolation or loneliness, pain or discomfort? What words are appropriate to describe her existence? Tucked in the end of the row, a baby seems almost too well to be in intensive care. A nurse brings a soother towards his mouth. He puckers his lower lip and rolls his tongue. Stroking the soother against the corner of his mouth, the nurse pauses for a brief moment. His eyes are fixed firmly on her. Taking the soothe in, he gives it a few short sucks before letting it fall off to the side. How does a baby experience a world of others? How does he experience a world of things? A world of technologies? For the most part, these are everyday observations that we could make in the NICU. There are moments that we might witness as physicians, nurses, respiratory therapists, social workers, or even parents. If we stop and dwell on the moments, the images and the descriptions, their stories, or fragments of stories, we may find ourselves emotionally stirred. Yet the critical challenge for parents and healthcare professionals is that if we really question what life is like for these children, we may find ourselves wordless or wondering. These are the ethics of the NICU. Our experiential understanding of the life of a newborn is always already framed from a perspective of distance. As adults, we can't simply recall what it was like to be a newborn, what it was like to be held or breastfeed, unless I guess you're some kind of Freudian. These events are remote from our memory. And even if we could reflect on such moments, we'd have to ask whether our vocabulary as adults is appropriately attuned and sensitive to this existence. Are words such as comfort, pain, distress actually appropriate to describe the life of a newborn? Or is a newborn's existence perhaps potentially even richer than such words can convey? Do experiences of touch, are they limited to particular modalities? Or do they span more than one sense? The other thing that we need to acknowledge from the start is that our ethical focus on the lives of these children, what meaning composes their moments, is ultimately formative of technologies. And technologies are formative of our experiences of them. So in this way, we can say the ethics of the NICU reflect a technomedical focus. So this is it. This is my premise for the talk. That the medical humanities offer the opportunity to explore human experience in itself and the meanings that give rise to experience. Now, my own research program is largely centered in the tradition of phenomenology, whereby experience itself, or how meaning arises, is considered the focus of inquiry. And although phenomenology is often understood to name a tradition in continental philosophy or a method for qualitative research, my own belief is that it's very much at home in the medical humanities. Particularly, we recognize that it enriches the medical humanities with the possibility to explore experience. Now, multiple philosophers within the tradition of phenomenology have recognized that technologies are ultimately formative of human experience. Perhaps none more deeply than Bernard Stollery. This French philosopher reminded us that our humanity is constituted by technology. The human being has always been a technical being. More so, he tells us that it is our prosthetic capacity to embody technologies, our so-called original human flaw, lack, or default, is what makes us human. So technologies serve to supplement or defer the lack, and yet the lack cannot be made good. The lack can never be filled. So for Stollery, our relationship with technology is co-original in the sense that the technical does not emerge out of the already constituted human, nor does the human out of the already constituted technical. So the fundamental moral question becomes, how ought we design and shape and use technologies, knowing that when we use such technologies, we are reinventing the kind of humans that we are each and every time? So for the practice of medicine, which by and large is a practice of technology, ethical questions relate to technologies. Right? Technology is understood in the broadest sense, not just as the mechanical ventilator, not just as the oscillatory machine or ECMO, right? But also all those technologies that structure how we come to interact with one another, right? So the institution of the hospital is a technology, right? Our healthcare system is a technology, right? Medical practice is a technology. This is a contemporary ethics case that I've fictionalized, all right? In fact, it's a recurring case that if you were to look back on the last year and say, what case has preoccupied people who work in my NICU, it's going to be something like this, right? And I'm going to share it in a bit of a medical way, all right? A medical case. Jessica is a 24-year-old G1P0 woman. Okay? So it's her first pregnancy, who presents with findings on her 19-week anatomy scan suspicious for trisomy 18. So generally, all women are encouraged to get an ultrasound done around 20 weeks, right, to figure out if there's something wrong with their pregnancy. She is told, this is a potential lethal anomaly. We're going to book you in for an appointment with a specialized maternal fetal medicine clinic to confirm. They should call you in the next couple of days. I know many of you are quite young here, maybe don't have kids of your own yet. I know there's parents in the audience as well. Do you remember that first ultrasound appointment? What it was like? As you kind of lay there on your back and kind of trying to read the expressions of the person doing the ultrasound, try and figure out what they're seeing just from their facial expressions. Can you imagine a moment of pause where they suddenly take a step back and you know that something's wrong? Then maybe they leave the room, you wait, they come back and take more pictures, then they leave the room and wait. This is an experience in itself. It's a technological experience. So what do? She goes home and she Googles. And we could say that her Google search finds two narratives. One is a medical depiction of trisomy 18. And when I was in medical school, this is what I memorized, right? And if you were to write your neonatology exam, probably the questions are going to look for information like this because it's testable material. Even now, when I give a talk for the medical school, I'm always asked to make sure I include testable material. And I struggle, right? Because anyway, that's another story. Yeah. So what can I tell you about trisomy 18? So when I was in medical school, not many years ago, right? Back in 2004, we were told this is a lethal anomaly, right? And in fact, it's an indication not to initiate newborn resuscitation. Why? Probably most significantly because we're told that every cell in these babies' bodies is different, right? It has an extra chromosome. And because of this genetic difference, it's an incurable condition. And it's a condition which involves various forms of anomalies, right? Or differences, right? So the head is small, the brain is underdeveloped. These babies are at risk for seizures. Maybe they can't control their breathing, right? Maybe even if you can feed them, the food won't move through their intestinal tract, right? Their bodily organs can be malformed, most significant when they have congenital heart disease. But there's also another narrative, right? It's a more human depiction. And this is where you find things like the I Heart Trisomy 2018, right? Various parent websites, which show that this is in fact actually not a lethal medical condition. Yes, these children are born different, right? They have differences, right? But when we begin to even say that these children are born different, that also expresses a particular ethics, because we're saying what is normal and what is other than normal. It's easy to imagine how a parent who's told that your child has a lethal anomaly, and then they go to a website like this, they immediately take on a perspective of, I'm going to need to advocate for my child. Now, the medical profession is changing, though. So this is from the American Journal of Medical Genetics, where there's actually surveillance guidelines, health promotion guidelines for children with trisomy 18, because you recognize that some of these children do survive and they grow up, right? But they still lead a very different life. Let's come back to our case. So the next day, she's called for a series of appointments with multiple specialists. The specialists are quite certain her baby has trisomy 18. These are the kind of words that you would see written in the consults and charts. Symmetric IUGR, the baby's very small. Maybe I shouldn't say baby, the fetus is very small. Bilateral choroid plexus cysts, right? There's differences apparent on the brain imaging. Brachycephaly, so the head is unusually small. Bilateral clenched fists, a very typical feature for fetuses within the womb who have trisomy 18. Absent left kidney, polyhydramnios. Well, a lot of kids are born with only one kidney, that's fine. But polyhydramnios, Lord, there's something going on here. Is the baby not swallowing the fluid within the womb? Or is there an obstruction in their intestinal tract? A large ventricular septal defect. So this heart is not formed normally. So what happens? She's offered amniocentesis for genetic testing, right? The gold standard. Let us show that your child is different. She declines. She's offered non-invasive prenatal testing, NIPS, right? Normally you have to pay for this in Alberta. I don't know about in Ontario, which seems the center of everything, but I'm sure someone will tell us later on. We offer it for free when we really want a parent to, end their pregnancy. She declines, and she's offered termination of pregnancy. Jessica and her partner, Charlie, are both teachers and have had some interactions with children with developmental differences and disabilities as part of their work. They know that disability doesn't equate with quality of life. But they also are aware that these children may have differences in their development and that medical interventions are not without potential pain and suffering as well. They have excellent family supports. They're both practicing Catholics and have supports from their church community. Jessica says, I want to give my baby a chance. I want to be able to bring them home. I don't know if I want to put them through surgeries as a baby, but I want us to be together as a family. She wants to do what a good parent would do, to provide those medical interventions that babies would normally be offered, regardless of genetic differences. Charlie has been mostly quiet during the conversations, but has voiced that he does not believe in abortions. However, he had not responded when asked about his beliefs regarding intensive interventions versus a focus on comfort care once the baby's born. He said, everything will be okay. Our baby will be fine. Let's just wait and see. What are the ethics of this situation? How would you respond if this was your pregnancy? If you were a healthcare professional involved in this situation, how would you navigate your responsibilities to Jessica, Charlie, and in time, their child, if it's born alive? A medical humanities approach to these kind of cases makes them more complicated. It helps us to see them, I think, with a richer perspective than what we would if we purely looked at the medical details. To be honest, this is sometimes rather disappointing to my colleagues in intensive care, because what they're looking for is things to be made easier. But in ethics, things aren't necessarily made easier, right? They're made more rich and nuanced, and we start to see different perspectives to a situation. So now we're in a situation of having to make various decisions for these kind of children. We're having to make decisions about navigating what is within a normal initiation or provision of medical technologies for a child. When we talk about putting a baby on IV nutrition, parental nutrition, which is standard of care for babies with most medical conditions who need it, should we consider this as something extraordinary for a child with trisomy 18? Should we afford them different opportunities, different thresholds for things like heart surgery? How does that speak to the ethics of resource allocation in our healthcare system? You know, when at any given time, we always seem to be at 100% capacity in the NICU. So in NICU, even if we go beyond trisomy 18, right, I can confidently say that we witness a manifold of these kind of stories, right? And invariably, the practice of working in an environment such as the NICU becomes all the more complicated when one begins to look at it from a medical humanities perspective. In fact, I would say medical humanities often helps us to see the ethics at play in a situation. So it's funny, you know, when people talk about medical humanities, I always think, you know, why aren't you in ethics? Right? Like, I mean, because this is really where ethics arises, right? When we start to look at these situations in this kind of richness. So the medical humanities offers us different insights into these kind of stories, different understandings that help us to navigate through them, to find a fitting response to them. Right? So my own understanding of ethics, how I explain ethics to medical students when I get to do lectures with them or nursing students, is I talk about ethics as it's not just about autonomy or justice or beneficence or non-maleficence, right? Those are concepts that we use to try and gain a hold of ethics, right? But ethics is actually in these kind of moments, right? That's where we see it. Ethics arises in situations when we're confronting someone other than ourselves, right? Whether that's that parent who finds herself emotionally stirred by their newborn child, trying to figure out what's the right thing to do for him or her, for them. Or whether that's in the lives of the healthcare provider, right? Who finds themselves responsible, not just for this child, but a unit full of children, right? And also their families, right? It's an incredibly difficult job, right? But it's an incredibly fulfilling job. So this is my research program, right? This is what I'm really interested in, right? Exploring things like how might we understand experiences like the life of the newborn, right? Recognizing even if we'll never be able to answer that question, we have an ethical responsibility to ask it, right? How do ethics arrive in the context of neonatal-perinatal medicine at the so-called beginning of life, right? You know, ethical issues in neonatal-perinatal medicine aren't just about abortion, pro-choice, anti-choice, pro-life, anti-life. That kind of dichotomy isn't helpful, right? It's rather asking, how is it that a child comes to be, right? From that perspective of where one parent may find themselves actually, before their child's even born, having ethical responsibilities to them, right? So I've, you know, been so fortunate to be involved with families who are expecting a baby to pass away after birth, right? They're expecting a baby who will not live a long life. And what they do in their pregnancy is they take their child for vacations, right? They go to Disneyland and take pictures. Now, for others, they have very different experiences of pregnancy, right? And as healthcare providers, we need to be aware and sensitive to different ways of experiencing, different ways of knowing, if that makes sense. Right? Recognizing we all might hold our own moral beliefs, right? I hold a moral belief that, a woman's right to bodily autonomy, we can't transgress that. I mean, that's my own moral belief. But different people have different moral beliefs, if that makes sense. How am I for time? 26 minutes. I have 4 minutes, right? Okay.
Oh, you're okay.
I'm okay. I have lots of time. Oh, great. Perfect. So I love it. I love it. I want to shift focus a little bit, right? Not shifting focus away from this topic, but rather look beyond the NICU and provide you a different empirical example. So I've been really fortunate to be involved also in various pediatric study research and also research outside of pediatrics to an extent. And one population that kind of has come up again and again, where we seem to have a perennial concern, are those children who live with ventricular assist devices. This is a schematic of a ventricular assist device. I wasn't sure who was going to be here, like, literature majors, may or may not know this kind of stuff, right? And honestly, even if you talk to many family doctors in the community, a lot of the stuff that happens in a hospital setting, like the University of Alberta, is kind of out there. It's space-aged, right? So what is this thing, right? So this is a VAD, which consists really of 4 parts. On the inside, here we have a pump, right? And that pump is surgically attached to the ventricle, right? The pumping chamber, and some way of pulling blood out of the circulation as well, right? So it's a mechanical pump. And it's attached by a drive line, right? A little cable that connects the pump through the skin, so it comes out of the skin, right? And attaches to a controller box. And it runs on electricity, right? It doesn't run on gas, even though it's from Alberta. So it's connected to a power source, which in this case is worn as a shoulder bag, or it could just as easily be in a fanny pack or a knapsack. Does that make sense? So why do we use this kind of a technology? Well, we use it for a number of different reasons, but most commonly in situations of heart failure, where the heart is failing to such a degree that despite the use of medications like epinephrine or norepinephrine, we can't seem to augment the cardiac output to meet the needs of the body, right? So it's for advanced cases of heart failure. Generally, it's understood to be something that's used for now, right? A temporary thing until a child can get a heart transplant, or maybe the heart's going to recover. But at times, we also wonder if it's going to be a destination therapy. This is a picture from the Stollery Children's Hospital newsletter. If you ever want to feel very uplifted that everything we do in healthcare is for the good of everyone, you read the newsletter, right? I'm saying that in clearly a sarcastic manner, but it's also being recorded, so I have to be mindful. Thank you. I have the utmost respect for people like who are depicted in this image, right? Like this is hard work and it's innovative work. And I know that when I see children who are living with these kind of technologies, literally holding an example of one of these pumps in their hand, it's extraordinary. And this is also kind of one of the crowns on like the Stollery Children's Hospital's head, right? Because this is very much, we were the first place in Canada to implant a Berlin heart, right, back in 2005. We were the first place in Canada to send one of these kids home to go to school, right, to play with friends with a ventricular assist device. So this is a technological achievement, right? But it also has a technological ethics to it, where we wonder and we worry, what are these children's lives like? What have they lived through? What are we prepared for them to live through? So I'll read a little bit about this study, just to give you a sense, which I'm hoping will enrich your understanding, because that's what I think medical humanities does such a wonderful job for. The story of a child who lives with and depends on a VAD begins with acute or chronic illness. His or her heart is failing as the consequence of cardiomyopathy, congenital heart disease, myocarditis, or some other affliction. When the option of a VAD is considered for a child or the family, the device offers the possibility for not simply a longer life, but also the opportunity to recover a semblance of what was disturbed by illness and hospital care. The VAD may allow a child to regain energy, strength, independence, and aspects of his or her life that otherwise would have remained lost. The VAD offers possibilities, leaving the ICU, transitioning to a hospital ward, and in time, going home. Once I got over the initial recovery from the VAD surgery, I found myself feeling better and better. I had more energy. I was less out of breath. I finally could do things just like anyone else. After they gave me the VAD in the hospital, I was allowed to go home. I asked my friend to come over and play. We had so much fun, I almost forgot that I now had this VAD. And yet, although a VAD may save a child's life, living with a VAD is not without potential changes, conflicts, and challenges. While some children seem to feel very relaxed and comfortable talking about their VAD, for others the experience is deeply personal. For some children, fragile emotions are slumbering just below the surface. I just want to get off this thing. I want to have a heart. The actual device inside of my chest sometimes makes a hum or like a kind of a buzz. And if I put my hand right into my chest, I can kind of feel the vibration of it. In a real quiet room, I can hear it. Sometimes during these times, I just can't help but think, I don't want it anymore, that I just want it taken out, that I'm just done with it all. The truth is, every child may respond differently to the implantation of one of these devices. And living with a VAD can harbor different emotions, feelings, and meanings for a child. From a phenomenological perspective, we can recognize that the VAD itself may give life in a particular way, shape, or form. These are some of the themes from this research work. And I'll just point to one briefly before I'm told, Michael, your time is up.
What is time?
Time is lunch. At night, I can hear the motor kind of. It's like a washing machine or a dishwasher sound. So I can hear that when I'm trying to fall asleep. But after a while, it just kind of gets washed away in the sound of everything else. Most children without medical complications are able to live their day-to-day life unaware of the health of their heart, lungs, kidneys, or other organs. The interiority of the body is tacit, overlooked, or silent. Perhaps while running, a child might feel out of breath, panting quickly, gasping, or a child may feel the pounding of their heart when called on to answer a question in front of their classmates. Moments of bodily noticing are the exception rather than the usual manner in which a child experiences their body. And even in these moments, it's not necessarily the organ itself the child notices so much as the condition of being tired or nervous. There are these moments when I just feel it. It's sore and painful. Taking a Tylenol doesn't help. Other times when we're just sitting at the dinner table, we can all hear its hum. There's an inorganicity to the placement and functioning of a VAD. Pressure, displacement, or distortion may result in the forced accommodation of the pump within the limited physical confines of the child's chest. And as the VAD mechanically delivers blood by continuous flow, the heartbeat is replaced by heart hum. For some children, the sensory mechanical machineness of the VAD may cause queasiness, nausea, and vomiting. Sometimes I feel yucky, not all the time, but sometimes it just happens, and then I do not feel good. I feel it in my stomach and I get sick. The VAD can be really loud and stuff. I hear the pump through the pillow. The pillow is like an amplifier. I need music to sleep, music to block out the sounds of the pump. Children seem to variably cope with the VAD's hums, vibrations, and other intergonicities. For the child who fails to habituate to the VAD's mechanical sensuality, we may wonder whether the child's body resists embodying the VAD, or rather the VAD is mal-embodied. Such moments may be evident when a child with a VAD is struggling to get to sleep at night, restricted by the driveline, or triggering positioning alarms. Sleep or pain medication may be required, or even the parent sharing the bed to help position the child so he or she can achieve sleep. The term malembodiment is not meant to refer to incomplete or partial embodiment, but rather dysfunction in the embodying of that which is to be embodied. The omnipresence of the VAD for the child becomes especially acute in a moment when the VAD is disconnected from the power source. Last night, when I went to plug into the AC, I accidentally pulled out both batteries. It made this really loud screech kind of sound. I had to plug it in right away because it started to slow down. It felt like something was just in me that just wanted to stop. I got this kind of grinding feeling and felt lightheaded. Once plugged in, I ended up just laying in bed for a little bit until I could recuperate. When the VAD is in the forefront of a child's awareness, whether momentarily or constantly, we realize how the VAD or complications from living with the VAD may not simply restrict a child's being in the world, but rather disrupt being in its entirety. Sometimes I get scared. I can feel it inside of me. I call my mom and dad to come, and all I want is just to get it out. Last night, I was just sitting there, just relaxing and paying attention to my breathing and trying to fall asleep, listening to its churning motor sound when I started thinking, started worrying about it stopping. I wonder how it might all end. I wonder about what might happen if it simply stops. We hope that living with the possibility or prospect of death is an experience that is foreign to children's lives. And so we may wonder about the psychology and the well-being of the child who must be connected to the VAD to live. So I'm just sharing those reflections, that portion of that study to again show just how enriching the medical humanities is to the practice of medicine. But again, I come back to say it makes things more complicated, right? There aren't just simple recommendations to how to deal with these situations, but rather these are situations that we find ourselves having to respond to. So with that, I'd like to thank you all for attending, to thank you for allowing me to present this wonderful conference and food. And I'd also like to thank the parents, the children and babies and my colleagues and staff who contributed to the various studies that informed this presentation. Thank you.
Thank you so much.
Thank you again for having me. Any questions from Edmonton? Oh, right in the front row. I'm going to bring the microphone over. That way I don't have to repeat it.
All right. You talk about how ethics, there's like such a human component to it, and about like answering human questions and considering that empathy with the advent of like AI and asking Chat GPT questions about like medical stuff. What do you think the role of AI will be in like the study of ethics?
So I think something we have to acknowledge that things like Chat GPT are ultimately human designed as well, right? And that's where we see the possibility in part for biases and other kind of ethical issues to become more complicated by them, right? So things like Chat GPT, I mean, how it's trained is based by and large on data that's been collected by humans, right? It's looking for patterns based on a particular objective mindset towards what is important, right? So to give you an example, if we collect data based on gender and we reduce it to a dichotomy of male and female, then chat is going to, fall prey to such kind of faulty biases as well, right? That being said, what I'm hopefully trying to present is, we can't really talk about human things and technology things, right? But rather technologies structure our humanness, right? So even right now in a presentation like this, our way of being with each other, of encountering one another, is entirely structured by our technologies around us. I have a microphone. My voice is somehow more important than everyone else's. No, I'm joking, right? You know, you're sitting down in a chair. I'm standing up. That structures our way of relating to each other. The fact that I can't see the screen right now I'm standing in front of for London, they're made invisible, right? In that sense of, you know, whether they're present or not in this presentation, right? I can't see people in the audience there to know whether they fell asleep or whether, you know, this presentation resonated with them, right? So it is problematic, I think, to talk about the human and the technical. I think it's heuristically valuable when you're trying to open up a situation, but recognize that that distinction that we're making between something human and something technical is also ultimately also a faulty dichotomy. Is that okay?
Yeah.
Okay, cool. There was a question in the back. Yeah. Getting my steps in.
I have a couple. One was, how long ago could they see on ultrasound the trisomy 18, like the chromosome there or not? How long ago did that technology?
Sure.
Oh yeah, I can share.
So trisomy 18, I mean, has been a diagnosis that's been in the medical literature for many, many decades, right? Certainly, you know, around the time that we talked about diagnoses like trisomy 21 or Down syndrome, you know, trisomy 18 has also been linked, right? As far as technology and when could we, I mean, we can never see chromosomes on an ultrasound, but rather what we see are features on ultrasound that make us suspicious. And what we've tended to do in medical profession is to try and get more data sources to try and say, how concerned should we be? And that's where we have the notions or ideas or concepts or activities like the triple screen, right? So they're not just looking at ultrasound data, but others to try and predict the risk of aneuploidy, which means an abnormality in chromosome number. Now, how this has impacted, you know, women's pregnancies is quite astonishing, right? So if you look at places like Iceland, I remember reading a story a couple years ago where they had no babies born with Down syndrome for a whole year or two, right? Because they all terminated the pregnancies as a consequence of the technologies, right? Right. So, I mean, I'm not gonna, you know, start going on whether abortion is right or wrong, right? That's not the point of this talk, but the point is merely to say that these technologies shape the nature of ethics because they create the opportunity for such a decision, right? But generally, we do identify in North America, based on our current screening protocols, you know, features suspicious for trisomy 18 early enough on in pregnancy that families are afforded to make their own decision about whether they want to continue the pregnancy or not.
Can these ultrasounds also determine one chromosome extra? I have a client that was one chromosome extra, and I'm just curious if they could.
Yeah, so generally, I mean, the only way to do genetic testing in the sense of looking at chromosome number would be to do something like amniocentesis or chorionic villus sampling. The emerging technology that's being used more and more is this NIPS or non-invasive prenatal testing, which is essentially allowing through maternal blood work, you being able to identify potentially genetic differences in the fetus. And that's become commercially available in places like North America. I mean, people have to pay for it, but it's a lot less invasive than amniocentesis. It's not 100% specific though. So, you know, in many situations when the NIPS is so-called positive, people may still choose to pursue an amniocentesis if they want to know definitively, if that makes sense. But ultrasound would never allow you to count the number of chromosomes, right? That's okay. Oh,
Quick question. Recognizing there's a question in London, I believe, I'll just ask if you have a reflection. I remember when you had your own children and you observing, they just felt so big and huge because you were so used to the small infants in the NICU. And what's that like to navigate as a physician, the land of the well and the unwell, as Susan Sontag,
I
in your
mean,
daily life?
in daily life.
Yeah.
So personal reflection, I mean, I would say that when as a healthcare provider, you become a parent as well, if that happens to you, whether that happens because you have a child biologically, right, or whether you adopt a child, it does change the way you practice, right? It changes the way that you speak to parents, right? It changes the way that you relate to others. I mean, I remember that experience of, expecting a child and suddenly going through the mall and walking around and feeling like I could just like nod my head at all these other guys who were like pushing a stroller along. I'm like part of that club now. Hey, yeah, you know what I mean? No, but there is something that changes, right? I used to try and tell the peds residents they should all try and get pregnant during residency. They'd be so much better pediatricians. Then I got in trouble from the program director. No, but no, I do think, our own experiences as parents does change the way that we practice, right? But one has to always be very careful that, I might have a particular experience informed by my own experiences, but our patients are going to have different experiences still, right?
I have no voice. I'm sitting here thinking about the NIPS versus like traditional amniocentesis and even the ethics of what you said in your presentation, that you can offer it for free when, as the practitioner, you're trying to lean someone towards termination. And just, is that because the NIPS is still so new that it's not free or covered, or like, why wouldn't we want to push for least invasive?
Well, I think that might also depend where in the country or North America you live as far as the social acceptability of things like pregnancy termination, right? So I doubt you're going to find the NIPS being offered for free in somewhere like Texas or the Texas of the North, which is Alberta, right? So I mean, different sociocultural beliefs about the acceptability of something like prenatal testing and pregnancy termination are going to influence what's afforded to families. So all I say to people is go out and vote if you live in Alberta.
Michael, it's Wendy Stewart. Thanks so much for your presentation. As a pediatric neurologist, a lot of what you said really resonates because I have a lot of kids in my practice, of course, that have developmental concerns of all different types. And I have discussions with families about their struggles with whether their child's life has meaning and matters to society. And I'd be interested, based on what you said, and I know this might take too long, so maybe it's something we can take offline, but how do you think we can impart those discussions and thoughts and reflections for our learners when there really never seems to be space in the curriculum to do those kind of things?
Ooh, a curriculum question. This is hard. My own perspective is there is lots of space in the curriculum once we value something as being important and formative for our medical learners or nursing learners or respiratory therapy learners or other health professional learners. I do think that this kind of learning in particular needs to also occur at the postgraduate level. So what do I mean by that? Students benefit from these kind of sessions and this kind of learning in residency or in clerkship when they're actually interacting with patients. Unfortunately, it's more resource intensive, right? If someone wants me to do an ethics talk for MD students, it's very easy for me to come and talk to all of them, right? For an hour, there's 150 are in the room. If I need to do sessions with all of the residents, how many sessions is that, right? So it's more resource intensive. But if we want it to be meaningful, I think medical humanities scholarship needs to make its way into postgraduate medical education, not just undergraduate medical education. That's my very quick answer. I now really want to hear the next speaker because he's a colleague and friend. So I'm going to pass it on to our wonderful host to introduce.
Thank you.